Chronic shoulder pain. It's got to be one of the most common and frustrating problems out there. It can mess with your sleep, your work, your workouts, but figuring out what's really going on in there can feel like a genuine mystery. Well, today, we're going to crack that case. So, when you walk into a doctor's office with that nagging pain, what actually happens next? How do they get from a general complaint, like my shoulder hurts, to a super specific diagnosis? We're about to find out. We're going to follow the clues, just like a detective. To do that, we're actually going to follow a real-life medical case from start to finish. We'll trace it from the very first visit all the way to the treatment plan. It's honestly the best way to see a doctor's clinical reasoning in action and hopefully demystify the whole process. Okay, so let's get this investigation started. It's time to meet the central character in our little mystery. All right, here's the case file. Our first set of clues. We've got a 51-year-old woman, and she's been dealing with left shoulder pain for a solid 8 months. Now, pay close attention to the specifics here. The pain came on gradually. It wasn't from a sudden injury or trauma. In fact, it started after she began a new exercise routine. The pain is on the side of her shoulder, and it really flares up when she tries to lift her arm over her head. And listen, these aren't just random details, right? Every single one of these is a vital piece of the puzzle. So, with these first clues in hand, a doctor's next move isn't to take a wild guess. Nope. Instead, they create what's essentially a list of all the potential culprits. This whole process is called a differential diagnosis, and it's basically step one in good medicine. You don't jump to conclusions, you line up all the suspects. So the very first question a doctor has to ask is a big one. Is the problem actually in the shoulder? You see, pain can be either intrinsic, meaning it's coming from the shoulder's own parts, the muscles, the joints, the tendons, or it can be extrinsic, which is trickier. That's referred pain that's actually coming from somewhere else, like your neck or even your heart. Now, based on her story, an intrinsic cause seems way more likely. Okay, so if we're focusing on stuff happening inside the shoulder, here's our initial lineup of suspects. It's kind of a rogues gallery, with everything from common rotator cuff issues and impingement to arthritis and the infamous frozen shoulder. Our job now is to dig a little deeper and figure out which one of these is our real culprit. All right, now we get to the next phase of the investigation. And believe it or not, the best tool the doctor has is just listening. We're going right back to our patient's story because every single one of those details is another clue. So this is how a doctor starts to decode that story, right? Each clue points them in a certain direction. Her age, 51, fits with a few different conditions. The fact that it started gradually makes a big, sudden tear less likely. But here's the real kicker. The pain with overhead movements, combined with the fact it's on the lateral side of her shoulder, man, that points a huge flashing arrow towards the rotator cuff and specifically something called impingement. So just based on her story, look how much we've already narrowed things down. Rotator cuff disease, or impingement, has shot right to the top of our suspect list. The others are still on the board, sure, but things like AC arthritis and those extrinsic causes, they've moved way, way down the list. The investigation is really starting to focus. Okay, now for the hands-on part. The doctor has a short list of suspects, and now they're going to use specific physical exam moves to either confirm their suspicions or rule them out. This isn't just random poking and prodding. These are very targeted tests. And this quote from the Yale medical curriculum just nails it. A physical exam is a science. Each one of these special moves is designed to stress a very specific part of the shoulder. And how the patient responds, whether it's with pain or weakness, changes the probability of one diagnosis being right over another. So let's look at a key test for our number one suspect. It's called the painful arc test, and it's super simple, but wow, is it powerful. The patient just lifts their arms straight out to the side, all the way up. Now, if the pain kicks in somewhere in that middle range, right between about 60 and 120 degrees, that's a positive test, and it's a huge clue that something in a very specific spot, the subacromial space, is getting pinched. And here we go. Here are our patient's results. She had a positive painful arc test. The pain started right around 80 degrees. She was also positive on something called the Fulkin test, which points a finger directly at one of the rotator cuff tendons. But what's just as important, are the negative tests. The drop arm test was negative, the external lag test was negative. Both of those argue against a complete tear. And a negative neck test pretty much rules out referred pain. The picture is getting incredibly clear. Okay, so the story pointed us in the right direction. The physical exam gave us the hard evidence, all the clues are on the table, and they're all pointing to one single conclusion. So, after all this detective work, after combining her story with those targeted physical tests, what's the final verdict? What's the diagnosis? The diagnosis, subacromial impingement syndrome, or SIS for short, and it is pretty much exactly what it sounds like. Some of the structures in the shoulder, like the rotator cuff tendons, are getting pinched or compressed in a really narrow space whenever she lifts her arm up. And that pinching causes inflammation and the pain she feels, especially with those overhead movements she told us about. And remember those negative tests we talked about? This is exactly why they were so important. They helped us refine the diagnosis. We don't just know it's impingement, we're pretty sure it's an inflamed, irritated tendon, something called a tendinopathy, and not a huge, full-thickness tear. And that distinction is absolutely critical because it completely changes the game plan for treatment. Look, getting a diagnosis is awesome, but it's only half the battle, right? The real goal is feeling better. So let's check out the game plan for getting our patient back on track. So the approach here is really smart. It's conservative, and it builds over time. You don't just jump to the most extreme option. You start with the basics, rest, changing up your activities, maybe lay off those new exercises for a bit, and using some anti-inflammatories. Then physical therapy is absolutely key to get that motion and strength back. It's only if those things don't work after 4 to 6 weeks that you start to consider something like a steroid injection. Things like MRIs and surgery, those are truly the last resort, not where you start. And this is maybe the most crucial point of this whole thing. We solved the case. We got an accurate diagnosis and a solid treatment plan. And we did it all without a single X-ray or MRI. Think about that. A careful history and a well-done physical exam gave us everything we needed. It saves time, it saves money, and it saves people from unnecessary procedures. And that right there is our number one takeaway. A systematic approach is absolutely everything. The patient's story, plus a really good, targeted physical exam, that's what equals a solid clinical diagnosis. It's the absolute foundation of medicine. This whole process just goes to show you all those little details about your pain, where it hurts, when it started, what makes it worse. They aren't just you complaining. They're signals. They're vital clues your body is sending you. So the real question is, are you listening?